This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting-edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health. Hello, Rational Wellness Podcasters. Thank you so much for joining me again today. For those of you who enjoy listening to the Rational Wellness Podcast, please go to iTunes and give us a ratings and a review. That way more people will find out about the Rational Wellness Podcast. And for those of you who don't know, we also have a video version, so you can go to my YouTube page, Weitz Chiro, and watch that. And if you go to my website, drweitz.com, there will be a complete transcript and show notes. Our topic for today is osteoporosis with Dr. John Neustadt. Osteoporosis literally means porous bones, and it refers to a condition in which the bones become fragile and the risk of fracture is increased. In fact, according to the National Osteoporosis Foundation, studies suggest that 1 out of 2 women and 1 out of 4 men over the age of 50 will break a bone due to osteoporosis. The most common sites of these fractures are at the hip, the spine, and the wrist. If you have osteoporosis and break your hip, there's a 40% chance that you'll be dead within 6 months. When you look at a bone density scan, if there is a T-score of 2.5 or greater, this is defined as minus 2.5 or greater. This is defined as osteoporosis. And a score of -1 to -2.5 is termed osteopenia, which is the loss of bone, though not as severe as osteoporosis. Thanks to a new paper that Dr. Neustadt just sent me, we now know that even patients in the 35 to 50-year-old range are suffering with bone loss. In fact, 28% of men and 26% of women in the U.S. in this 35 to 50 range have some loss of bone. As I understand it, one of the ways that we should understand osteoporosis is that throughout our lives, we have a balance of both cells that build new bone, osteoblasts, and cells that clear out old junky bone, osteoclasts. When we are younger, there's a tendency for the osteoblasts to dominate, and we tend to build more bone over the osteoclasts. And then when we get older, there's a tendency for this to become reversed. Dr. John Neustadt is the founder and medical director of Montana Integrative Medicine, and he's the founder and president of Nutritional Biochemistry Incorporated and also NBI Pharmaceuticals. He's written 4 books, including A Revolution in Health Through Nutritional Biochemistry, and he's published over 100 research review articles. Dr. Neustadt, thank you so much for joining me today.
My pleasure. So great to be talking with you.
Excellent. So why do you think we're having such an epidemic of osteoporosis and osteopenia in the U.S. today?
Great question. It's typically understood to be a disease of us getting older. And with the baby boomers getting the 65, 70-year-old range, the general population of the United States skewing older, it makes sense that as we get older and we are more likely to lose bone, that the prevalence of osteoporosis and the risk of osteoporosis goes up. In fact, the fastest rate of bone loss for women is after menopause. The 10 years after menopause is the time when women lose bone the fastest.
And that's because it's related to estrogen levels.
Correct. Estrogen is considered anti-inflammatory. It also helps to build bone and maintain bone. And when that gets lost, you can get bone loss.
Now, we understand that women are programmed essentially for their hormone levels to drop after menopause a lot, their estrogen and progesterone levels. But men are not really programmed for that to happen. So why should men necessarily have a similar sort of risk as women?
Well, they really don't, actually. This new study that you quoted is new research. It's groundbreaking research. I think there needs to be continuing studies, but it is incredibly alarming. The understanding currently of osteoporosis in men is that it affects about 20% of osteoporosis cases are in men and 80% are in women. So disproportionately women are affected. This new research is very alarming, though, in that it's showing, first, that bone loss is occurring much younger than we had anticipated and thought. And second, that it is occurring potentially at a rate much higher in men than we thought as well. What may be happening is that the rate of bone loss or the risk for osteoporosis, and I'm speculating here based on the research, may be similar for men and women. In the study, the loss of bone was very similar in terms of the percentage of men and women in that 35 to 50-year-old age group who had lost bone and became osteopenic, have pre-osteoporosis. And then as they get older and into menopause, you get that drop in estrogen. What may be happening is then women actually start losing bone faster than men because they've lost that estrogen. And at that point, they're actually outpacing the men in terms of the rate of the onset of osteoporosis. And we wouldn't know if men are more susceptible to that younger, because all of the research to date has really been with osteoporosis. And in fact, not osteopenia, in the screening guidelines, the United States Preventative Task Force for Osteoporosis doesn't even recommend that men get screened for osteoporosis because it appears to be, based on the research that they looked at, so infrequent in men compared to women.
Well, it may reflect sedentary lifestyle and poor diet.
Absolutely. There's definitely that component to it. And I think it's important to note that the most important risk with osteoporosis is not the low bone density. That's a number on a test, or what's called a surrogate marker. That's not clinically the most dangerous thing about osteoporosis, or the most important that people need to worry about. The most important risk with osteoporosis is breaking a bone. As you correctly pointed out, if you fracture a hip and you have osteoporosis, then there's up to 40% chance that you're going to be dead in 6 months. If you happen to survive the first year, there's actually a 20% chance that you're going to end up in nursing home care and you're going to suffer from chronic pain or other complications from that fracture. So anything that we do clinically, and everything should be interpreted, both the testing and any recommendations, through that lens of how predictive is the test for predicting a fracture, and what does the research show in terms of what my doctor or what I'm reading is recommending I do. What does the research show in terms of its ability to actually prevent a fracture, not just change bone density? Because since the 1990s, we've known that a bone density test only predicts 44% of women who will break a bone and only 21% of men, which is shockingly low. It's neither specific nor sensitive. The World Health Organization, the American College of Obstetricians and Gynecologists, anyone essentially that's looked at the research, have published position statements on this, have correctly concluded that fracture risk depends on factors largely other than bone density.
So what are some of those factors?
Great question. So medications is a huge factor. We live in a completely over-medicated society. A lot of people don't know, and they're popping these like candy and taking them for years and years. Acid-blocking medications, the Protonics, the Prilosec, Zantac, those were never approved by the FDA for long-term use. Yet not only are they being prescribed for years for symptoms of acid reflux to suppress the acid, but now they're available over the counter without a prescription. The research shows that after 4 years of taking them, over time, the risk continues to increase for osteoporosis and hip fracture, the most dangerous fracture. Then after 4 years of taking them, that the risk for a hip fracture increases by 60%. Another common medication, prednisone. Oral prednisone can strip the bone of its minerals, calcium, and cause osteoporosis and increase the risk of fractures. Premenopausal tamoxifen, if someone's had breast cancer, been treated with tamoxifen prior to going through menopause, that's also a risk. There's quite a list of medications that can cause that. The number one predictor of a future osteoporosis fracture is if you've had one already. So if you have osteoporosis, you've had a previous fracture with osteoporosis, That's the number one predictor of a future fracture. Medications are an issue. Other diseases that you may have, anything that causes malabsorption, like Crohn's disease, ulcerative colitis, celiac disease, those are risk factors as well. So autoimmune diseases where there's systemic inflammation, that's a risk factor as well. And one of the, sedentary lifestyle, not exercising, that's a risk factor. Poor diet is a risk factor. There's good research also showing in terms of risk factors for osteoporosis that what we want to prevent is falling, because the number one event to occur just prior to breaking a bone typically is somebody falling, right? So that's where the sedentary lifestyle, the not exercising comes in, that if somebody doesn't have that balance and strength, then they're more likely to fall and fracture.
I've really been enjoying this discussion, but now I'd like to pause to tell you about the sponsor for this episode of the Rational Wellness Podcast. This episode is sponsored by Pure Encapsulations, which is one of the few lines of professional nutritional supplements that I use in my office. Pure Encapsulations manufactures a complete line of hypoallergenic, research-based dietary supplements. Pure products are meticulously formulated using pure, scientifically tested and validated ingredients. They are free from magnesium stearate, gluten, GMOs, hydrogenated fats, artificial colors, sweeteners, and preservatives. Among other things, one of the great things about Pure Encapsulations is not just the quality products, but the fact that they often provide a range of different dosages and sizes, which makes it easy to find the right product for the right patient, especially since we do a lot of testing and we figure out exactly what the patients need. So, for example, with DHEA, they offer 5, 10, and 25 milligram dosages in both 60 and 180 capsules per bottle size, which is extremely convenient. And now, back to our discussion. Some people say that what appears to be a fall that results in a fracture is actually a pathological fracture of the hip that then results in a fall. Or is that true, or is that not really true?
So
does that occur in some cases?
Yeah. The only cases where it's really noteworthy is when people are taking bisphosphonate medications, right? It's pretty rare unless you're running, you have really weak bones, you come down so hard. But most people who fall, they lose their balance.
Okay.
There's no evidence to my mind. It's sort of a chicken and the egg thing. What came first? It is understood that typically a fall precedes a fracture. And when that doesn't happen, when the fracture happens first, what we're looking for is medication-induced fractures. Like if somebody is taking Fosamax, for example, and that provides the pattern of fracture in a bisphosphonate break is a very specific pattern of fracture. And it's a non-traumatic fracture, so that can be differentiated.
So let's clarify for people who are listening. Bisphosphonates are a classification of drugs that are prescribed for osteoporosis, correct?
That's correct. They're the most prescribed medication. They go by names of Fosamax, Zometa, for example. And like anything, the end goal, hopefully the goal clinically is to reduce fractures. So the question is, well, how much do these reduce fractures? The bisphosphonate category of medications reduce fractures about 45%. Those are hip fractures vertebral fractures. Vertebral fractures can cause pain, but they're not going to kill you. It's the hip fractures that kill you. And what's been shown is Fosamax actually doesn't even prevent what's called a primary hip fracture. If you have never had a fracture before, it has not been shown to actually prevent a first fracture. And paradoxically, which I think is a little insane, that even though it's rare, these medications that supposedly are supposed to prevent a fracture actually in rare cases actually increase people's risk for fracture. Not something we really want to do clinically.
Like unusual fractures, like femur fractures.
Correct. It's called a unicortical break in the femur, non-traumatic. So there are cases in the medical literature of a woman actually, she was watering her plant. She's on a step stool and she stepped down. She didn't fall. She stepped down and twisted a little bit and her leg just broke. And what happens when somebody's on the medication, it breaks, it actually reduces their ability to heal from that. So it takes them longer to heal.
Now, can you explain how these bisphosphonates work, the mechanism of action?
Yes, they poison the osteoclast. So as you mentioned, there are two main cells in the bone, and osteoblasts and osteoclasts. Osteoblasts build bone, osteoclasts break bone down. It's a process called bone remodeling. And it's important, it's necessary. It has to be in good balance to break down old, used up bone and build new, fresh bone to maintain healthy bones. That's important. And what the bisphosphonates do is they poison the osteoclasts. So the osteoclasts stop working. And so you get the osteoblasts keep working. They keep building up bone, but it's abnormal bone. It's weaker bone.
You're not clearing out the old junky bone that should be cleared out to make stronger bone.
Correct.
Now, I've heard you talk about the fact that to prevent fractures, you mentioned the fact that bone density tests are not the most accurate test. And that's because there's a flexible part of the bone, right? That's not
Correct.
Measured by the density. Can you explain what that flexible part of the bone is?
Absolutely. It's the connective tissue in bone. So bone is a tissue, and like all tissues in the body, it's made up of different substances. The bone density test only measures the mineral content of the bone. The minerals in the bone give bone its hardness, but there's collagen, bone collagen, that gives bone its flexibility and actually gives bone what's called its quality, its ultimate strength. If you were to take, and in fact, when I was in medical school in my histology class, the professor soaked a chicken bone in acetic acid, in vinegar. And what that does, it strips all the minerals away from it. And when all the minerals are gone, all that's left is the collagen, the connective tissue. And he brought it in, and it's like it's a rubber chicken bone. It flexes, it bends, but it doesn't break. And so that bone collagen, that connective tissue, is crucial, and that's not measured on a bone density test, nor is it taken into consideration typically in the conventional approach to looking at bone health and treating osteoporosis.
So if bone density tests don't tell us about the true ability of a bone to resist fractures, are there any tests that do? What about urinary tests for bone resorption markers? What about measuring serum osteocalcin or undercarboxylated osteocalcin?
Great question. So I want to make sure that I'm very clear in what I'm saying, that I don't completely discount a bone density test. It does have some predictive value, but I think it's important to put it in its proper perspective in place. It's one piece of the puzzle. It's one piece of data to consider, but most times when people come to me with their bone density test, there's a lot of anxiety. They've got the diagnosis of osteoporosis. They're very scared, and that's all they're focusing on. So it's important just to step back and I think put it in its proper perspective, that it is one piece of the puzzle, and by no means is it the most important piece of the puzzle. Yes, there are other tests that are what's called surrogate markers. They're markers that can look at different indicators of potential collagen or connective tissue health in the bone. They go by names that you said, osteocalcin or undercarboxylated osteocalcin, N-telopeptide, which is NTX, or CTX is another one, C-terminal peptide. And the challenge with those, and why I don't test those anymore, is because there are no prospective studies showing that changing that value actually changes fracture risk. And in fact, with the undercarboxylated osteocalcin, there was an animal study done some years ago in mice, in rats, where there was what's called a wild type, just a normal rat that produced normal amounts of osteocalcin. And there was a genetically altered rat that was created that didn't produce the osteocalcin. And after 6 months, the rats that did not have the osteocalcin actually had stronger bones. And it just shows that the story that we've learned about, one marker leading, and one result is maybe too simple when it comes to bone. And we need to look a little more holistically. And why I don't test is because the only reason we should test any patient and run any test if it's going to change our approach to treatment. And what I've learned over the years and working with thousands of patients and doing my research and lecturing and digging into the research is that none of those tests accept a bone density test will change my recommendations in terms of my approach.
One of the companies is offering the undercarboxylated osteocalcin as a functional measure of vitamin K status.
And yes, that is a functional measure of vitamin K status because vitamin K is required to carboxylate it.
So is it valuable for that purpose, or is it valuable to measure serum vitamin K, and do you also monitor vitamin D levels?
So I do monitor vitamin D levels. I don't typically monitor vitamin K levels. If they have osteoporosis, they come in with a diagnosis of osteopenia and osteoporosis. And by the way, why osteopenia is, for me, such a huge red flag with that research that we talked about is because there's 2 studies that came out years ago that showed that people with osteopenia are actually at higher risk for fracture than people with osteoporosis.
Really? How can that be?
Well, that's a great question, and people ask me that a lot. I don't have a definitive answer. I think that there are a couple different potential answers. One is people may not be taking it as seriously. They get the diagnosis of osteopenia, so maybe they're not as protective with their bones, or not as proactive with their diet and exercise and maybe dietary supplements or medications if that's indicated than people with osteoporosis are. So that's one potential explanation. I think that's probably the simplest explanation, but I don't know for certainty that is the correct one. Nobody's really teased that apart. But with respect to testing, if somebody comes in with osteoporosis, I don't really, the only thing that I would test is vitamin D to see if I need to supplement at a level much higher than I normally would. But vitamin K I don't test because what I go off of, what do the clinical trials show, are the nutrients that people can take that have been shown consistently to reduce fractures. So there are 4 nutrients that have been shown to reduce fractures, and only 4 in clinical trials. So calcium and vitamin D have been shown to reduce fractures about 20%, which is okay. The strontium has been shown to reduce fractures about 45%, which is no better, no worse than Fosamax. And I'm not a fan of using strontium as a first line, and I can go into that a little bit if you want after this. I talk about the next nutrient. But my first line therapy is a specific form of vitamin K called MK4, 45 milligrams per day. That's been approved as a medication in Japan since 1995 for the treatment of osteoporosis and bone pain caused by osteoporosis. There have been over 7,000 volunteers studied and followed for up to 8 years on that dose and higher. People with postmenopausal osteoporosis from medications like prednisone, and bone loss in children, people with autoimmune diseases and bone loss. And it's consistently shown that not only can it stop and reverse bone loss as indicated by a bone density test, but again, that's not the most important clinical thing. It doesn't reduce fractures, but repeatedly it's been shown to reduce fractures by over 80% when combined with the calcium and vitamin D. So my go-to is that MK4. There are different forms of vitamin K, but it's only the MK4 form of vitamin K that's been shown to reduce fractures. All forms of vitamin K will change that osteocalcin marker blood test. But again, that's not the most important thing clinically. It's what's been shown to reduce fractures. And it's only that MK4 form that's been shown to reduce fractures. And there are over 25 clinical trials on osteoporosis, and 5 of them specifically looked at fracture reduction as the endpoint that they were evaluating.
The use of the MK7 version of vitamin K2 is much more common, more popular in the U.S. right now. And this may be since serum levels of vitamin K stay elevated longer after consuming MK7 than MK4. And since MK7 is converted into MK4, shouldn't taking MK7 be as effective as MK4? So
great question. First of all, MK7 is not converted to MK4. Vitamin K1 is converted into MK4.
Okay.
MK7 is not produced by mammals or humans. It's produced by bacteria. So gut bacteria will produce some amounts of MK7, and then it gets absorbed into our bloodstream.
Okay.
Vitamin K1 can be converted through a specific enzymatic pathway in our body into MK4, which then gets stored in different tissues in the body, throughout the body. I've heard that argument before, that MK7 lasts longer in the body. It's got what's called a longer half-life. Therefore, it must be superior, it must be better. But again, is that the most important thing with osteoporosis? The half-life of a substance. If that were the case, then Fosamax would be the best thing to take, because it'll stay in the bone for years and years. No, the most important thing is, does it reduce fractures? And again, MK7 has never been shown as an endpoint in a clinical trial to reduce fractures. And they are different molecules. They are both vitamin K, but vitamin K is a category. And as different molecules, they have a little bit different effect on the body. MK4, for example, has been shown to have anti-cancer effect that MK7 does not have. And in fact, they're up to phase 2 clinical trials in Japan with MK4, 45 milligrams and up to 135 milligrams per day for acute myeloid leukemia and myelodysplastic syndrome, blood cancers, also liver cancer. And MK7, in contrast, has been shown, if someone were coming to me and says, I have coronary artery disease, I have atherosclerosis, and that's all they were worried about, should I take MK4 or MK7? I would tell them to take MK7, because the research supports MK7 more than MK4 for being able to potentially promote arterial health and decalcify arteries. But with respect to bones and osteoporosis and fracture reduction, the research overwhelmingly supports MK4.
Wow. So if we really wanted a comprehensive anti-aging program, we should probably be taking K1, MK4, and MK7.
You could, but there are other nutrients. I like the anti-aging program.
No, I know. Just in terms of the vitamin K part.
Yeah, it's yes, you could, but frankly, I think that it's to get the clinical doses of all of that gets very expensive.
Right. So in terms of supplementing for osteoporosis, you mentioned taking the MK4, calcium, and vitamin D.
Correct.
What level do you try to get the vitamin D level up to? Do you try to get it up to 60 to 80?
I love it. Anything above 60, I think, is great.
Okay. Yep. What about adding magnesium? What about adding boron? What about adding strontium, vitamin C, antioxidants?
Great questions. Great questions. So you find a lot of those in bone health supplements. And frankly, you find them in multivitamin and mineral supplements too. And in a good, high quality multivitamin and mineral supplements, those nutrients should be there in adequate amounts for broad spectrum support.
But you don't get a lot of magnesium in a multi, really.
Depends on the multi. I mean, the one that I created has 150 milligrams of magnesium per serving. So I don't know if that's a lot to you or not.
I guess it's not to me, no.
Right. So it depends on what the target is. But here's the bottom line. The most important question is, has magnesium, boron, the other nutrients that you mentioned.
Strontium.
Strontium, I said, has been shown to reduce fracture.
Okay.
But have magnesium and boron or other nutrivitamins C, have they ever been shown to reduce fractures?
Right.
The answer is no. They've never been shown to reduce fractures. And so for me, clinically, when I'm working with patients and wanting to use what I think is the highest evidence, which is the randomized clinical trials, and we can get 80+% fracture reduction verified in multiple clinical trials just with the combination of MK4, 45 milligrams a day, calcium and vitamin D, and I'm targeting bone health and just osteoporosis as an osteoporosis supplement, that's what I would use. And in fact, that's what I created because I needed it to help my patients and I couldn't find one that worked. So I created the product. I couldn't find not one that worked. I couldn't find one that had the nutrients, the combination and the dose of nutrients shown in the studies to work. So I created it. And then the other nutrients that you mentioned, if I'm a big fan of magnesium, huge fan of magnesium. And I think, and the research has shown that over half of the population don't consume adequate magnesium in their diets, that having it as a supplement is important. But if we're just targeting osteoporosis, there's no research showing that it reduces fracture risk. And so I like to move people more towards a whole foods diet magnesium, green leafy vegetables. Every center of the chlorophyll atom has a molecule of magnesium in it. So that whole foods, Mediterranean style dietary pattern, whole foods diet, very rich in all those nutrients we just mentioned, except for the strontium.
So there's no reason to get 2-to-1 ratio of calcium, magnesium, or anything like that.
So there's no study showing that that actually affects absorption that I've ever seen. I keep asking people, please send me a citation, send me a study. For me, it's reached the status of myth out there, and I've yet to have anybody actually be able to send me a study. It's theoretical that one may compete with the other, or you need them in a certain ratio. But in terms of fracture reduction, to get that 80+%, it was MK4, 45 milligrams a day, vitamin D, and calcium, and that's it.
If the key is the collagenous part of bone, there's going to be more about supplements. Is there any benefit in taking things that are known to help with collagen, like glucosamine sulfate, bone broth, collagen protein?
Great question. So for me, the question I'm going to always go back to, and that I really work with a lot of people, that osteoporosis.
Let me guess. Is there any studies showing that they've decreased fracture risk?
That's exactly right. That's it. It's not complicated in my mind. What are the studies showing it reduces fracture risk? And dietary supplements and taking supplements can get very expensive for people. And so what we know in terms of maximum fracture risk reduction are those 3 nutrients that I mentioned. Medications, if necessary. I'm not opposed to them, but I think if the best fracture reduction on a medication is on Forteo, which is only available by injection. But what has been shown to reduce fractures or falls and fall-related injuries in osteoporosis? It's diet, exercise, but MK4, 45 milligrams a day, calcium, and vitamin D and strontium, but I don't like to use strontium.
Peptides have become very popular, and there's one called BPC, Body Protective Compound 157, and that's been shown to stimulate bone healing, at least in some of the animal studies.
I think that's wonderful preliminary research, and I'm definitely open to learning of new things that actually work. But as a clinician, I'm going to go back to that same question. Just because it's in an animal study doesn't mean it translates into humans. And we see that over and over in medical research. And what happens is you see a lot of these companies that are coming out with these raw materials, like Algacal, for example, or the MK7, and they'll have studies, and every time the study will report, you look at it, it'll report increase in bone mineral density. Well, ask the question, has it been shown to reduce fractures? Because we know that a bone mineral density test only predicts 44% of women, only 21% of men who will fracture.
Since estrogen is protective of bone, should postmenopausal women take bioidentical estrogen?
I think that if they are showing symptoms of hot flashes and insomnia and other symptoms of low estrogen and issues with that, then that is a good clinical indication to potentially supplement them. There is research taking estrogen and what are called selective estrogen response modifier. Those category medications, Evista, for example, is one of them, can reduce fracture risk. So should they take it? There can be some risks with taking those. So that would be something to be decided only in consultation with their healthcare provider who knows their medical history and their risk profile.
Since there's such a problem with these bisphosphonates, what about salmon calcitonin?
Salmon calcitonin I've used to help people heal from fractures in the elderly. And it's got some good research on it. But as a long-term solution, the fracture reduction is not great.
Okay. One thing I thought that was interesting, I heard you say in one of your talks, this is a little bit of a tangent for those of us in the functional medicine space, is that if you have a patient who's in a condition where they're losing bone, we may see an increase in heavy metals in the blood, since some of these metals tend to get stored in the bone. And I think that's pretty interesting because a lot of us are dealing with chronic patients, some of whom have heavy metal toxicity, and we may find that sometimes their heavy metal toxicity continues even though we're using some protocols that should be reducing their heavy metals. And we may not be considering the fact that if they're in a state where they're losing bone, they may be continuing to liberate more heavy metals into their bloodstream. And so, if we're dealing with a patient like that, especially with a postmenopausal woman, we might consider the importance of trying to get their bone situation stabilized.
Absolutely. So if there are risks, for osteoporosis, and if somebody does have one of those risk factors, even the U.S. Preventative Task Force says any women under 65 who are premenopausal with risk factors for osteoporosis should be screened for osteoporosis. So they don't really, on their radar is not the heavy metal toxicity, but definitely on mine it is, and it sounds like it's on your radar as well.
Yeah. So what's the best kind of diet for increasing bone density?
So the best, over 60 years of research, without a doubt, the Mediterranean pattern style of eating. And I really, it's referred to as a Mediterranean diet, but I really want people to understand it's not as if you're going on a diet. It's an eating pattern. It has its own food pyramid, and it's really basically a whole foods diet, getting those nutrients that we talked about, the minerals, the vitamins from whole plant foods, very high in whole grains, and at the base of the pyramid, vegetables, like I said, whole foods. As you go up, lean proteins, so you've got legumes in there, chicken and fish maybe weekly. It's the opposite of the standard American diet, which is a lot of red meat and highly processed foods. And in the Mediterranean eating pattern, red meat is consumed less than weekly, maybe once every couple weeks, and in moderation. Water, ample water, exercise. It's really an eating pattern, but it's also a lifestyle.
It's kind of hard to know when you start reading all the articles on the Mediterranean diet. And don't get me wrong, I've seen a lot of positive studies, but there's a lot of confusion from study to study exactly what constitutes a Mediterranean diet. You mentioned whole grains, how much pasta, how much bread is there. People talk about legumes, is cheese part of it? Olive oil, red wine.
Right.
I'm not so sure it's that clearly defined a diet, but I get your general point about it.
I totally agree with you, and you hit such an important point of how confusing this research can be for somebody. So here's my overall emphasis is that typically people, when they come to me, and probably you as well, where they're at in their eating is really far from where it should be.
Right.
And a lot of it is just people becoming aware of it. And so the first thing I do with people is I have them quantify. I break it down to the number of grams of total fiber and the number of grams of protein they're getting a day. And that total fiber needs to come from whole foods, not a supplement. So that would be the green leafy vegetables. That could be some legumes. And I shoot for a minimum of 30 grams of total dietary fiber a day, and they have to quantify it. And for a couple of days without changing their diet. And same with their protein requirement is calculated based on their body weight. And so over 6 weeks or so, I worked with them to transition into eating more of a whole foods diet. I'm not a fan of dairy, as you and I discussed prior to the podcast. The biggest reason is I don't think it's a great source of nutrients, but there's so many hormones in there that I don't think are real. They're not healthy. And a lot of people react to dairy. They can have allergies to them that they're not even aware about. They get stuffy nose, postnasal drip, gas and bloating, that sort of thing. So I'm not a fan of dairy. And the dairy in Europe and the Mediterranean is very different. They have a different regulatory environment for the hormones that they allow, what they allow on their crops. And our crops are unless it's organic, are quite poisons with glyphosate, pesticides, and recombinant growth hormones in the beef and that gets into the dairy. And so I counsel people eat as organic as possible. If you feel that you can't afford 100%, stay away from what's called the dirty dozen, the 12 most pesticide-laden fruits and vegetables. And if you can see what it was.
For those of you who don't know, that's from the Environmental Working Group, publishes a list of 30 dozen of the fruits and vegetables that are most likely to have a lot of pesticides.
Exactly. And, and then there are just some general rules of thumb that I guide people on. If you can look at it and know where it came from, it's a whole food.
What about soy? Should women be eating soy?
In moderation. I don't have a problem with it. I'm a big fan of moderation. And look, if somebody wants to have a little dairy every once in a while, okay. I'm not really fanatical about most things.
Could soy be beneficial because of phytoestrogenic effect?
It can actually. It can. Again, it's never been shown to reduce fractures. But yes, soy does have some benefits, but then it gets into the question of how much do you really need to eat to get those benefits?
What's the best type of exercise for improving bone density, preventing fracture of bones?
Yeah, great question. The best exercise is one that helps people improve their balance to reduce the risk of falling and fall-related injuries. So a lot of people think that when they get the diagnosis or they got to start exercising, they have to go to the gym, they've got to start pumping iron. And that's what people want to do, great. But for a lot of people who don't want to do that, it becomes an impediment to them doing anything because they're under that impression that that's what they need to do. But the research shows that anything you do to improve your balance will reduce the risk of falls and fall-related injuries. So that can be gentle yoga, that can be a qigong, even going for a walk on uneven terrain where you're walking up and down, over a curb, anything that sort of improves that balance. And I wrote a blog on it, what's called the stork exercise. I love things that people can do in their house. There are ways to work exercises into people's daily routine so it just becomes part of their life. So the stork exercise, while storks, they stand on one leg while somebody brushes their teeth, and brush your teeth should be 2 minutes a day. While you're brushing the bottom teeth for a minute in the morning, you stand on one leg and you can kind of hold the sink if you want a little bit to balance yourself, but try not to use it as a crutch, not too much. And you stand on one leg and the bottom teeth for a minute, and you time it, and then when you switch to the top teeth, you've got a Sonicare or something, it times it for you. Switch to the top teeth, you switch legs. And you do that twice a day, and that's been shown to improve balance. They're just little things that people can do.
But hasn't resistance training, weight training, doesn't that stimulate the muscles to pull on the bones, which causes the bones to get stronger?
Weight training and that sort of training has been shown to improve bone density. And absolutely, it has benefits. And I do encourage people to do that. It can be isometric. It doesn't even necessarily have to be weights. It can be somebody's body weight as well. But I'm also a fan of trying to meet people where they're at. And not, it's treating the individual, because there's a lot, if somebody doesn't want to go into gym, or maybe they can't afford it, or it doesn't fit into their day, or they're not motivated enough to do it, there are ways to get them to start doing things proactively that can be incredibly beneficial. And then maybe over time, maybe they get the exercise bug and they want to do a little bit more, is what I hope. And they can always build on those successes.
Great. I think that's all the questions I have. Any final thoughts you want to leave our listeners and viewers with?
This has been a fantastic, a lot of fun talking with you, and hopefully your viewers have gotten a lot out of it. I think it really boils down to that one question I kept going back to, and I try and educate people over and over. The most important question, if it's a test to ask the clinician, is how predictive is this that I'm going to break a bone? How well does it predict my fracture risk?
Right. Oh, you know what? There is one more thing I wanted to touch on. The idea of trying to eat a more alkaline diet.
Yeah. So I'm a fan of that, only in the sense that what is an alkaline diet? It's a whole foods diet. It's a whole foods plant-based diet. So if that's what people like, and it's really popular, they like that you can test it, the pH strip, you can test your urine to see if it's getting more alkaline. I think that's great. Whatever's going to motivate somebody to take charge of their health, take more responsibility, and get excited about eating well. I think it's fantastic.
But is there really something to, if your body is more acidic, you're going to strip calcium off the bones to balance out the pH in the blood? Is there anything to that?
So there's research that's been shown looking at people who consume meat, and meat tends to be rather acidic, and that'll increase calcium excretion in the bone.
Okay.
But that's very different from saying you've got increased calcium. It'll increase calcium excretion in the urine. So you're peeing out calcium. But it's very different to say, there haven't been studies that I'm aware of at least that make that next connection to say, okay, people eat an acid diet, their calcium is increasing in their urine. Well, is that because the calcium that they're absorbing, they're just peeing more of it out, or are they actually stripping it from the bone? And is it creating osteoporosis? So if you're eating that way, regardless of if people want to characterize it as acid or not, which it is if you're eating a high meat diet, the research is very clear. That's not a plant-based whole foods diet. And that is a risk for osteoporosis. Whether the mechanism is the acid or not, I'm not sure. Maybe there are people who are more expert in that can more definitively answer that question. But the bottom line is that is a dietary pattern that is not a whole foods plant-based diet that has been shown to create osteoporosis. And it could be because of the acid. Well, but it could also be because of nutritional mineral deficiencies.
Yeah, and besides meat, the other area of controversy you keep mentioning all whole food plant-based diet or is like grains and beans. And,
correct.
Grains generally are considered to be acidic.
Correct. Everything in moderation. It's a balance. I'm not saying eat grains with every meal. I'm not saying eat that's the majority of your meal, the majority of your nutritional source. It should be a balanced diet. So for me, I love, I'll have, spinach and green leafy vegetables and a rainbow of colors from bell peppers and carrots and, other fruits and vegetables. And then maybe also have on there some a sweet potato, for example, for my starch. Not always a grain. There are other ways to do it. And a lean protein like fish, like soy, tofu, or something like that. There are different ways, but there's also protein in vegetables. And I think people lose sight of that. Vegetables do have protein in them.
Okay, good. Excellent. So, yeah, I think you've provided us with a lot of great information to think about in terms of improving our bone density, reducing our risk of fractures, and helping those of us who are practitioners for helping our patients to reduce their risk of fractures. What's the best way for us to get a hold of you?
The best way would be through my website, nbihealth.com. NBI stands for Nutritional Biochemistry Incorporated, so it's nbihealth.com. If they want to reach me, there's a contact form or a toll-free number on there, and they can reach me through the form, or my staff can always forward any messages to me from.
Are you still seeing patients?
I do all pro bono consulting work now by phone with people.
Oh, okay.
So I'll see people by phone, maybe 2 or 3 a week to help them. But they're not officially my patients. I help them understand what questions like this they can go back and ask their doctors, what tests maybe they're missing. I synthesize things that have been going on with them, help them understand, reframe what's going on. I'll recommend dietary supplements, lifestyle, diet, have them talk about medications or testing further with their healthcare provider.
Great. Excellent. Thank you, Dr. Neustadt.
Thank you so much.